this is 71-year-old man, he had a 3-vessel cabbage and a maze, and then these are his numbers. So, someone's, okay, so good. So first question, so first of all, dead or alive? So what were the 2 numbers we look at first? Yeah, those suck, right? So this patient's going to be dead very shortly if we don't fix it. Okay. So then the first thing we look at, heart rate rhythm, right? Okay, so 132. So why is that concerning? Well, he had a maze, so most likely he's in, this is AFib RVR, right? Okay. So I would say with this pressure and this index, we're not gonna mess with EMEO. And we don't, unlike the cardiologist, we don't give the total or delta lot. Why? Because they're negative inotropes, right? So I would cardiovert this patient.
Because you give him a boatload of heparin in the OR, you don't worry about, and you'd already seen that there's no clots like the day before or something. When you do TEE, you're not worried about cardioverting him?
Yeah, so when we do a maze, we always, it's very rare that we would not ligate the left atrium. If there's clot, then we will go take out the clot. But you're right, if there's a patient who had AFib, unknown duration, and unknown left atrial appendage status, then you don't want to cover them. Okay. What else? Do you see anything else on the screen that's concerning?
CVP is pretty high.
Pretty high. Okay. What do you think about the CVP relative to the PA pressure?
Your PA diastolic and your CVP are pretty similar, so it just means blood's not really getting pushed too forward.
Yeah, in fact, the CVP is higher than the PA diastolic. That's messed up. It should be the other way around,
So
right?
tamponade city.
So, one thing to be concerned about is it tamponade? And the other thing is if it's not tamponade, then it's severe right heart failure. Because the right heart is so fluid overloaded that it's more overloaded than the left heart, which means that this is severe right heart failure. Okay. So let's say we cardioverted him, we get that. So what's the next move? So we took care of heart rate, heart rhythm. Now we're thinking about stroke volume. So preload, do we have enough preload?
Yes.
Yes, we have too much preload, right? Okay. Afterload is just blood pressure. And yeah, it's okay-ish, yeah. And the main thing is we don't want too high of an afterload, but that's generally not the problem here. So then we will go to contractility. Okay, so that's basically how we make our decisions. Rule out heart rate, heart rhythm, rule out anemia, hypoxia, preload, and then so then this patient would start, if they're on epi already, would start epi. Now, generally the course of a patient is coming out of the OR, coming off pump, we optimize them in the OR to have an adequate index in SpO2. From there forth, you should be weaning the drips. Now, it could be slow, it could be fast. We set our pace usually at 0.005 to 2 hours for epi. No one will usually buy the daily loop. If there's an interruption and you have to go backwards, then you have to say what is wrong. Because generally the hearts should be recovering from the operation. So if you get stuck, then we have to go back to all those things that to start with, figure out, is your SpO2 wrong, is there discordance, is there anemia, is there hypoxia, or other things. And then if figured out all those things and things are not matching up, then we get an echo, see, can we drop the graft, is there some other problem? It depends on operation. Okay, what questions y'all have? Yes?
Why don't we really use SVR here?
I use it sometimes because generally what we're treating is cardiac function, right? SCI, SpO2. If those are adequate and the blood pressure is very low, well, it's not cardiogenic. Because basically SVR is vasodilation or blood pressure, right? If it's not cardiogenic in nature, then it's usually just a vascular tone issue.
A lot of times when they come back, it seems like I said, they're paced at 90. Their milliamps are set maybe at 20 or even higher. Are you okay with us finding the threshold where that
I would love it
works,
if you guys
or-
did that.
Okay.
It's crazy. Even on the floor, you guys don't go to the floor much. I'll see patient, the wires are out and the box is going. So I'm sure they're burning through batteries. But yeah, because if you can, so what do you use for threshold?
I just mean like sometimes if the pacing wires aren't picking up as well or whatever, you can, increase the milliamps and that'll correct the problem, but we don't have a lot of room to go sometimes when it's already at 20.
Yeah,
So-
so it depends a little bit on on the position of the heart and all that. So generally, what we do is we find out, so you drop the pacing a little bit at a time, figure out at what milliamps it stops pacing. Then I generally set it 10 above. Here, I think just by the culture is just set it at 20. Now, the less milliamps you use, the longer the wires will last. So that's why sometimes it's better to just be 10 above the threshold. But sometimes our wires aren't very well placed or whatever, and so even at 20 may not be adequate. And then what we do is switch the A's to the B's, you get to 25.
Okay, just want to make sure you're okay with us changing that, because we didn't know. I have another question. Nobody
Weird.
else has any?
I have one too.
I know you got to shoot for extubating quickly. I'm assuming there's research or something like, there's a good reason for extubating fast. Is there a better recovery to the patient?
Better
for-
recovery, faster recovery, less pneumonia, shorter length of stay. And so I didn't talk about it much, but the vent also has effects. It varies. Some patients, the vent has no effect on their hemodynamics. Some patients, because of that positive pressure, it can cause some decreased cardiac function. So that's one reason. And sometimes we'll go through everything and everything's fine, and the next low we say extubate and see if that helps. But we should be aiming for what we call fast track extubation. And I wish it would, I feel like fast track, we should just call it normal. Because having a patient on a ventilator a long time, you're not really getting that much out of it. As long as they're extubated. What else?
Okay. Why do we focus so much on base deficit, and to correct it, why would we ever do normal saline? Like, how does a base neutral do anything for your base
Second
deficit?
question. So
I know.
so the base deficit, it depends on what's causing it. If the problem is hypopneumonia, that's what we give. So let's say you have a base deficit. If the CVP is low, you give volume, right? If CVP is high, then giving volume is not the right thing. In general, if you have an acidosis, you would like to not just give bicarb, because that just sort of doesn't, it's a band-aid and it'll fix the root problem. But sometimes the acidosis is so severe that, like I said, it can impact the contractility, it can impact how well your ion drips are working. Sometimes you will just go ahead and correct that bicarb so that all the other stuff can work. You can get into this cycle where stuff doesn't work, so then it gets worse, and then it's not so good.
So then the saline just kind of like tries to wash out.
No, the saline is to correct hypopneumonia.
Okay, but not
Because the base deficit is due to hypopneumonia.
Yeah. Okay.
But my understanding is we still don't have bicarb in the hospital, or?
My words on eBay.
How much do you think? I'm trading for a grilled cheese sandwich.
Why?
What else? Do you want? I talked mostly about coronary, but do you guys have questions about dissection?